Hello. Good afternoon, everyone. Good afternoon. How are you all today? I am Dr. Faith B.Yisrael. And I am here to discuss with you managing the COVID-19 outbreak that is currently happening at our Scarborough General Hospital. Just let me know if you are hearing me okay. Welcome, Gypsy. Hi, great. Thank you for joining. Welcome, Anne-Marie. Thank you for joining. I am doing pretty well. Good day. Hi, Ingrid. Thank you. Visual is a bit blurred. Is it still blurred? Let me know, because I am seeing it pretty well here. What I'm recognizing though is that my internet may be having some issues. Hi, Anne. So is this better? I'm determining whether I should start over or not. Is this better? You all listen, you all now seeing me, you all now hearing me. Is this better? Give me some feedback. This is what happens when you live in Trinidad and Tobago. So Anne Marie, does that mean it's better? Is that better? Hearing no. Great. Okay, good. Good. All is well now. Great. Okay. So guys, thank you so much for sticking around. Thank you so much for me to figure out this audio sound issue. All right. So let's do this. Share the live again now so that everybody who was there before can join back in. Share the live again. Share the live. So I am Dr. Faith B.Yisrael. I am the assemblyman in the Tobago House of Assembly. I am a behavioral and community health scientist. My doctoral degree is in public health. My undergrad is in neuroscience. Wow, I forgot that. Undergrad in neuroscience, I have a Bachelor of Science in neuroscience. I have a master's in public health and a doctoral degree in public health from the University of Pittsburgh Graduate School of Public Health. Again, thank you all so much for tuning in. Thank you so much. So what we're planning to do today is very, very simple. What I want to do today is to just walk us through how I think we can solve the issue at the Scarborough General Hospital, because we are definitely having an issue at the Scarborough General Hospital with the COVID-19 outbreak. I want to do a couple of things though. First, I want to share a definition because there seems to be a big hoopla between myself and other health professionals and everyone, it seems, at the TRHA and the Division of Health, Wellness and Family Development about what some words mean and the definitions of some words and so forth. So I want to start by sharing with you a definition or two of the definitions that I would be using, because this is the critical issue as it relates to how we define some of these words that they have been using at the TRHA and at the Division of Health, Wellness and Family Development. Before I do it though, I wanted to say that one of the reasons I'm doing this is because I spent the entire weekend having people call me all weekend. People were calling me all weekend. And when I say people, I mean professionals at the hospital. By professional, medical professional, I mean ranging from doctor, nurse, all the way to cleaner, all the way to people working in the kitchen, all the way to wards maids, a wide range of people. And they were calling because they were either COVID positive and were scared about how we are managing the COVID situation there. They were COVID negative and scared about how we are managing the situation there, or they are waiting for the results and scared about how we are managing the situation there. Bottom line is they were all scared, worried about how we're managing the situation because they are not convinced that what we're doing is the absolute best and it is going to get the best results. Now, this is important to start with because we all know that for you to fix a problem, you first have to know what the problem is. You first have to define the problem. You first have to understand the problem. And after you've understood the problem, then you could figure out how to get a solution, how to make it better, right? Part of the problem is that we are not willing to have real conversations about what is actually happening on the island and to be honest about what is happening on the island. So I am going to start by sharing with you. Let me know if everyone is seeing it. This is from the UK government website. As you see, COVID-19 guidance and support. Make sure everybody's seeing that COVID guidance support. And we're just talking about an overview, definitions of outbreaks and clusters in particular settings, published 7th of August 2020. And let me just go down really quickly so that you see, it talks about what COVID-19 and so forth, and then it goes very clearly into definitions. We are talking about non-residential settings, for example, school and so forth, right? A cluster is when you have two or more tests confirmed cases of COVID-19 among individuals associated with a specific non-residential setting with illness onset dates within a 14-day period. And this is the critical part. In the absence of detailed information about the type of contact between the cases. What does that mean? Good afternoon, everyone. Thank you for joining, Cheryl. Thank you for joining, Rhonda Ann. Thank you so much. That line that I underlined, why is that critical? It is critical because you use the term cluster if you do not know how these people have gotten sick. So this may be the situation. You may have let's just say two nurses on a ward getting sick, right? Now, it's very possible that those two nurses got sick at home. You know, we have COVID going on all over the island, all over the country. They both got sick at home in their respective homes. Or maybe they are really good friends and they went online somewhere and got sick. This had nothing to do with the hospital, but they both got sick. You picked up that both of them are sick, but you do not know what is the link between them. You do not know how they got sick. You do not know where they got the sickness from. You don't know if this is associated with the hospital or this is them liming on their own or whatever. You do not know. Okay? That is where you use the term cluster because it is critical that you, in the absence of detailed information about the type of contact between the cases. And then you have the definition of an outbreak. Two or more test positive for COVID-19 among individuals associated with a non-residential space within a 14-day period. And one of the identified direct exposure between at least two of the test confirmed cases are within the setting, meaning you can identify that this person got it from this person because they are known as contacts. They were close to each other. We know that one got it from the other. And where there is no sustained local community transmission, absence of an alternative source. So where we know that they did not get it from outside, in essence. They did not get it from outside, right? Now, the reason why we have a difference between cluster and outbreak, the main difference is that with the outbreak, we can identify where it came from. We know where it came from. We can say, yes, we know that this person picked it up in the hospital, and now there are 5 cases because these 3 nurses worked on the same shift, because this ward's maid came in and was in contact with these nurses, because This person who works in the kitchen came in and brought the lunch and was interacting with a patient, and we know that that patient is patient zero, meaning that is the patient that we know. We didn't know that the person had COVID when they came in, and they interacted with everybody, and we now have an outbreak on the ward or on the wherever. This is how we know when we use the word cluster. Cluster meaning we don't know. Cluster meaning we don't know how these people are infected. But outbreak meaning we do know, we have an idea, we did the investigation, and we know that this is the situation. It's important to know the difference. It's important to understand the difference, because one allows you to recognize that you have some level of control over what is happening, meaning we know we have cases, we know we have more than normal, but we have an understanding of where those cases are coming from. That is when we use outbreak. But when you say cluster, it means we really don't know. So I think that those individuals at the TRHA and at the Division of Health, Wellness and Family Development are trying to use the term cluster to prevent us from having fear, or to prevent us from being scared that something is happening. But the reality is something is happening, and we need to look at it straight on. We need to accept that, yes, this is what is happening, and then we need to act to stop it in its track and to prevent it from getting even worse than where it is right now. Now, let me share something else with you. I'm sharing a piece of a news conference, a press conference that happened. Uh, when was it? Last week, last Wednesday, I think it was. It was a press conference that happened last Thursday or Friday, because Health had their press conference either Thursday or Friday. And Liz William asked a question because they had been trying to get a sense of how many health professionals are sick. And they keep not really answering the question. So Liz Williams came back again and asked the question again: how many professionals are sick? What is your policy? And this was their answer. Now, let's see if you can hear this. Let me start from scratch.
Elizabeth, you can go ahead.
Hi, good morning again. Elizabeth Williams, TV6 News. Was just wondering if Dr. Thompson could tell us the total number of health workers who additional that have tested positive for COVID, because I have a figure here in terms of specifications of an additional 3 doctors, etc. But the total number of additional medical persons I have here is 30. I don't know if that number is correct. And we are also getting reports of some medical workers who are exhibiting flu-like symptoms. They are being still asked to report for duty. Are you aware of this?
All right, thank you. Dr. Thompson.
Let me take the second one first. So in terms of what the policy has been, if you come to test as a healthcare worker associated with either a cluster or for surveillance testing, once you report symptoms, you are issued a quarantine order at the green room where we do the testing. Now, of course, if I show up and say I have a headache, no one can look in my head and see that I have a headache. So you have to take it on trust that a person reporting symptoms. So that has been the policy. We have had situations, isolated situations, where persons may not have said that they had symptoms or may not have been issued a quarantine order because they were healthcare workers, and that would have been an oversight. But those issues are being corrected or have been corrected. In terms of the first question, what I can probably do for you, Ms. Williams, is give you an idea of over the last couple of weeks, how many people would have tested positive. So I have the numbers here. So I'm just gonna go back to week 10 So we are currently in week 17, right? So in week 10, we would have tested 21 healthcare workers, 7 positives. In 11, 22, 5, 12, 23, 3, 13, 37, 14, 34. Week 15, which was when we first identified the adult medical ward cluster, we'd have tested 76 healthcare workers and gotten back 15 positives. Week 16, we'd have tested 46 healthcare workers, gotten 18 positives. In week 17, we've tested 37 healthcare workers and gotten 8 positives. That period of reporting ends on, just give me a second, would have ended on the 14th. Yeah, so you may have different numbers from that based on counting yesterday's results, although I don't think we had any positives yesterday. So I think we should more or less, our numbers should line up.
Okay, so if you listen to the question was, there are health workers who are either sick or have symptoms, sick meaning who have symptoms, and they seem to be telling them they have to come to work. And how many healthcare workers are there sick? Basically, were the two questions that Liz asked. I listened to the week by week outline and I did some calculations, and it seems like between the week 10, which is where he started to call out the numbers, and the week 17, which is where he said ends on the 14th of July, there were 67 cases of health professionals being sick. 67 cases of health professionals being sick, and that is up to the 14th. I have been getting calls all weekends about the number of new cases of health professionals between Friday, Saturday, and yesterday, Sunday. And the numbers are not one and not two. I am waiting for them to do their press release or to do their thing on Thursday or Friday or whenever they do it, for them to say exactly what the numbers are, because we are getting the daily positive cases. But so, for example, today I think we had 18 cases. I am not sure how many of those are health professionals, but I know for a fact that it is more than one, it is more than two, it is more than three of those are health professionals. Same thing applies to the day before. So you have to ask yourself, 67 between week 10 and now, and how many, and that was up to the 14th, but how many since then? How many since then? And this is why I decided to do this today, because I am afraid that we are going down a road that if we do not halt it quickly, if we do not hit the brakes real fast, and if we do not reset really quickly, we're going to be in for some rough times, particularly since Trinidad and Tobago is opening up, particularly since our borders are open for the most part. People are now beginning to line up for food, and we have more people outside and around and about. So if we don't protect our health facility, then we are going to have a serious issue, because we have other health issues other than COVID that we need to take care of. And this is why from day one, last year, March, April, May, I was begging for us to have a real parallel healthcare system. And by parallel, we mean completely parallel. We mean separating staff, separating physical space, separating gloves and equipment and that kind of thing, because you don't want these two things mixing, because you will end up with what is currently happening right here, right now. So I want to share with you, and I'm actually sharing it because I don't want it to seem as if I am doing anything that is actually groundbreaking. I don't want it to seem as if I am doing anything that is actually great, that is actually, that you need a doctoral degree to do. No, I am sharing with you a Public Health Ontario. So this is the public health agency in Ontario, Canada. Best practices for managing COVID-19 outbreaks in acute care settings. Our hospital is an acute care setting, and it was revised in July. So within the last couple of days is when it was revised. Within the last couple of days is when it was revised. So I want to just share from you, and I'm sharing this to say that it does not take, we don't have to start from scratch. We don't have to reinvent the wheel. We have had the benefit of learning from other places, learning the mistakes that they made in other places. We've had that benefit. But for some reason, we are not using the knowledge from other places to our benefit. I'm sharing this so that you know this is not Dr. Faith B.Yisrael who is thinking of these things. This is just plain old simple. This is what is there out there already that we can work on. Let me see if I could make it just a little bigger so everyone can see. Let's do it this way. Let me look at the bookmarks because I had bookmarked certain places. So yes, so this is a very short book. It's Canada 50 pages. Outbreak recognition. It's important to know that when they are talking about outbreaks in a hospital, they are looking at surveilling patients and staff surveillance. So you have to look at ensuring that both the staff and the patients are well taken care of. And it's important, I want to highlight the first line, early recognition of COVID-19 outbreaks is critical as to allow control measures to be implemented prior to prolonged and widespread exposure of patients and staff and before the outbreak can spread to additional wards or facilities. I got an anonymous email today stating that the same thing that happened in medical ward last week, meaning there was an outbreak in medical ward last week or the week before, even though they are trying to say it is not an outbreak, the same thing is happening in the surgical ward. I got confirmation that the kitchen staff, they have a whole lot of cases. So we are already past the point of it not spreading. What we should have done was identified very, very early that we have an outbreak in one ward and clamp down very quickly to fix it. That is what we should have done, but no. We hear playing all kind of guinea hen bring ram goat story and doing all kind of thing to pretend that all is well. Patients should be screened for COVID-19 symptoms upon admission and should undergo surveillance for COVID-19 symptoms at least twice daily while admitted. That should be a part of the process. Somebody should be watching them all the time, because the reality is you may not have a situation where you can test every single person who comes in because of, well, in our case, it's because we didn't plan. And because we didn't use our resources well enough, because we never got the PCR machine from Trinidad. We never got, all of those things that we should have gotten a year ago to ensure that we could actually screen every single patient that comes in. And it says here, symptomatic patients should be placed in droplet and contact procedures and tested for SARS-CoV-2. Remember, SARS-CoV-2 is the virus that causes COVID-19. Droplet and contact precautions and tested for SARS-CoV-2. And let you see one time. I'm going to show you what droplet and contact precautions look like. Let me just stop sharing this really quickly and share another video again. This is not from me. This is what is out there.
Putting on droplet contact precautions with eyewear. Sanitize your hands thoroughly to make sure your equipment goes on clean. Next, put on the gown. Your gown may be different than this one. Be sure to tie it in the back and not in the front. Put on your gloves over the cuff of the gown. Next, put on your mask. Be sure you have a tight seal around your nose. Now put on your face shield or goggles and make sure that you have it adjusted correctly. Sanitize your hands. Now prepare to enter the room.
My question is, are individuals who are working in the hospital right now, individuals who are in contact in the hospital right now, because we know there's an outbreak in the hospital, are they putting on all of those? Are they wearing goggles, masks, gown, and gloves? Those four things are what is needed. Those four things are needed. That is what is known as very simple droplet and contact precautions. This is not new. This is not groundbreaking. This isn't new. This is just standard infectious control precautions, standard infectious control mechanisms. Do we have shields, masks, gloves, and what do they call it? The apron. Do we have those? Do we have enough? Because we now have a situation where the entire hospital is a place where there are infected people. The entire hospital. So do we have enough of those things to protect our workers? If every single worker who is going through the hospital now is not wearing those, because remember, we have a situation where it seems to be running out of control. And that is why what I am getting from the health professionals is that they are so scared of going to work. And you can't be upset with them for being scared of going to work. They are scared of going to work. So patient surveillance is one thing. Staff surveillance. All staff members with symptoms consistent with COVID-19 should notify their occupational health and safety department and should not come to work. Staff who have had unprotected exposure to COVID-19 in either the community or the health facility should also notify their public health. They should track all staff members based on the areas that they work, meaning, whatever unit they are in, and they should track them based on the kind of job they do. Because, for example, you may have a situation where you may have social workers, and the social workers are go to different wards, but they come together in the social work, in their office. So you have to track them based on where they work, but also based on the category of staff that they are. And it should be sure that everybody should be tested for COVID-19. Now, the thing about testing everybody for COVID-19 is that it only works if you get back the results quickly. And we are recognizing that a big thing that is happening now is that we are not getting back the results quickly enough. So somebody may be tested and they have to wait several days, up to a week, some even more than that, to get back their results. To get back their results. How do you do initial investigation? If you have a single nosocomial patient, the word nosocomial means hospital acquired infections. I know that there are several individuals who are, when you look at their situations, when you look at how their COVID infection happened, when you look at what's going down, we know for a fact that those people got COVID in the hospital. Those patients got COVID in the hospital. There were situations, and I won't be specific, where the individual even died, and the only way the individual could have gotten COVID would have been in the hospital, because their friends and families and everybody else who were contacts were negative, and the person spent significant time in the hospital. So this is if you have a single case, what to do. If you have a single case, what to do. They're telling you to ensure that patients are aware. If you have a single staff case, what to do. But if you have multiple cases happening, it's very different. And here are some immediate actions. Place all positive patients in droplet and contact precautions in single room or cohort with other confirmed positive cases. Ensure that all positive staff are in home isolation. All positive staff. They are not talking about all positive staff who are symptomatic, because one of the things they need you to do very quickly is identify all positive staff, because we know that asymptomatic people can transmit it as well. So we want all staff to be, as long as they are positive, to be home isolation. Assess all patients in the outbreak area. So in whatever ward it is, ensure that they have their own toilet situation. You can't have a situation where you have patients from a particular ward or staff from a particular ward going to the toilet in other areas, or going to, the staff room in other areas, because that kind of commingling is going to cause problems. It is going to cause problems. You should notify us about new patient cases, and whenever there are new staff cases, consider placing the entire unit in droplet and contact precaution pending review. So put everything in, the gloves, the mask, the goggles, put everybody like that until you really, really lock it down, until you really, really have good control. If that is not initiated, at minimum, patients should be confined to their rooms except for medically essential tests. Pause admissions and transfers until the situation has been thoroughly reviewed. Restrict visitors and essential care partners. Initiate contact tracing of all positive patients and staff. Place all exposed patients in droplet and contact precautions in a single room. So and what is not here, because it's understood, is that there needs to also be significant sanitizing of the place when we are to clean it up. I mean, the same way we've been closing down our offices and closing this down for the day and sanitizing and that kind of thing. The same thing has to happen here. It has to happen here. There needs to be an outbreak management team, and that team needs to be made up of people who can actually act. You don't want a team, for example, who is made up of people who are outside of the system, who then have to go and get permission from the CEO, or who have to go and find the money somewhere else. No, we need people who can act and act quickly to ensure that what is needed to happen can happen quickly. And this is one of those things. This is one of those things that cost can't be a factor, because we have a situation. If remember, it's only one hospital we have. I know the week before election, they run and open the Roxborough Hospital. I know, but no hospital services are happening there. The week before election, they run and open the Mariah Health Center, but no, nothing is happening there. We have one hospital up in Signal Hill, so you have to consider, what is it going to cost to fix this, to lock it down and fix it quickly, versus if we allow it to just multiply and get out of control with our one hospital? What is going to happen? What is going to happen if we just allow that to happen without managing it? And this is a perfect example. This is a perfect example of where, last year, and I say it all the time, last year, when the Minister of Health and the Prime Minister and all of they were there saying that they're taking all of these millions of dollars out of the Heritage and Stabilization Fund, and that is what they were using to do this, that, and the other. And we asked, what about Tobago? Is Tobago getting any of that Heritage and Stabilization Fund money to do these things? And the Minister for Health at that time very clearly said, no, this is I responsible for the Trinidad RHEs. I responsible for doing this in Trinidad. And if the Secretary of Finance wants access to Heritage and Stabilization Fund, the Secretary of Finance needs to go and apply to the Minister of Finance himself. That was the answer. So we got last year $50 million to health, $50 million to tourism, and a $10 million to something else. And that seems to have been the money that we got last year, while they were taking all of this money out of the Heritage and Stabilization Fund and managing the COVID response in Trinidad. So we should not be worried about doing the right thing because we don't have money. No, we have had access to money. We just didn't actually do it in Tobago. So we have the management team. Rapid case identification and contact tracing, that is clear. You have to ensure that you very quickly, managing COVID means doing several things. One, identifying who has COVID and who has COVID quickly. That means you should be able to test and within hours get a result. 24 hours should not pass without you getting a result for a COVID test, especially in Tobago where we have 60,000 people. That's it. We should never be in a situation where 24 hours passes and we don't have a result for somebody who we have tested, because we should have the capacity here to do that for 60,000 people. We were getting the PCR machine, but we told them no, we didn't want it. And now what is happening is that all of our samples are still going down to Trinidad to line up with all of the samples in Trinidad. That is part of the problem. That is part of why we are not able to get a result as quickly as we should be getting our results within hours. There's no one in Tobago who should be tested for COVID-19 who should not know their result within a couple hours. That is the way our system should have been set up here. So we have contact tracing. Again, key actions. Test all, because remember, we are now in a management system. We are now in a management time where we have to fix the problem and fix it quickly. Test all asymptomatic. Asymptomatic meaning they don't have any symptoms, but we do not care. We have to shut down and manage this thing. We have to test all asymptomatic, unvaccinated or partially vaccinated, meaning you only got one of the two shots, patients in the affected unit. Test all asymptomatic or unvaccinated or partially vaccinated staff in the affected areas. And the way it seems now, that is the whole hospital, because we did not act quickly enough when it was only one unit or one ward or one area. Consider the need to test asymptomatic, fully vaccinated people as well, because we know that even if you are fully vaccinated, you still can get COVID. You could get a breakthrough infection and you could still pass it on. So if we have the resources, test even the fully vaccinated people to ensure that they don't have a breakthrough infection and then infecting others. Strongly consider repeat testing of patients and staff every 3 to 5 days, just to make sure. Forward all of information as it relates to contact tracing, so that we know somebody who is positive has been in contact with, and work very closely with public health, work very closely with everybody to make sure that all of these systems working together. And then when we identify who is positive and who is not positive or not positive yet, we go to rigid containment. And again, I'm just going down to the key actions. The unit should be closed to admissions and non-urgent transfers, because again, you want to shut it down. That is what we're going to have to do, unless there's something that is absolutely critical. And you see, we only have to do this now because we waited so long and we allowed it to get out of hand. If we were only doing this for one unit, then that would have been easy to shut down one unit, lock it down, make sure everybody who is kind of inside stay inside and everybody who's outside stay outside, basically, and then contain it there. But we didn't do that. We allowed it to multiply and to go to other units. Another thing I heard them say is that one of the ways they've been managing the staff, having so many members of staff go on quarantine or on home isolation and so forth, is that they've been rotating staff. Now, I understand from a purely HR perspective, that may be fine from a purely HR perspective. But when it relates to COVID, that is not an HR management methodology that we should be using, because you are now again mixing different categories of staff that you needed to keep separate. You needed the possibly sick staff to stay in the area where they are possibly sick. You don't want to then bring in staff from another area to bring them in the sick ward to then send them back out to the not sick area. You don't want to do that as it relates to managing COVID, managing an infection. You don't want to do that here. The people who we know are in the wards or in the areas that are not affected, leave them out there. Let's get additional people. Let's get Ministry of Health to get people. We have nurses I know there are nurses who I taught way back when who still waiting for work. We have retired people who are out there. Let us use our volunteers and whatnot. That is what we need to do to ensure that we have this system closed, because that is what is necessary. Visitors to the unit should be restricted, of course. Patients who require urgent transfer to another unit for medical reasons should be transferred in droplet and contact precautions and remain in quarantine for 14 days from their last day, so that you have quarantine. Even while you are in the hospital, you have to have a quarantine kind of system before you come back in. If patients were transferred during the period of transmission in the unit but prior to recognition, the receiving unit or facility should be notified, and the patient should be placed in droplet and contact precautions and tested. Staff members working on an outbreak unit should not work in other areas of the facility where feasible. So there shouldn't be no in and out. There shouldn't be no rotating of staff. All you're doing now is infecting everybody. That is what you're doing now. You're infecting everybody by rotating the staff in and out. Interrupting the transmission. And again, I'm just going through the key actions. And again, you'll realize this isn't faith talking. This is what is in a manual that is already there. All we have to do is utilize it. Key actions: place all patients on droplet and contact precautions. Ensure PPE supplies are sufficient and accessible by staff. This has been a complaint that I have gotten from day one. We have doctors and nurses telling me personally that them had to buy their own gloves. I don't care what anybody who is in authority says. There is a PPE problem at the hospital and at the health centers. It doesn't matter what anybody says there is, because if there wasn't, not one single doctor, nurse, whoever should have been buying their own PPE. They shouldn't have to buy their own glove and carry their own glove. That needs to be taken care of. You need to review all policies, make sure that they're up to date, and make sure that they're working. Review the practices that are happening in the different units to make sure that what is written in the policy is actually what is being done. Again, audit the practices. That is basically what that is. Audit the practices. Review staff vaccination rates and promote staff vaccination. Provide education on key elements. Provide education on symptoms. Consider the use of safety coaches on the unit to monitor and provide feedback on hand hygiene. Because remember, this is something that you need to be very, very clear on. So you need to make sure that everybody doing it the way it should. We should have these safety coaches, which are really infectious control people who basically standing up there and watch you like a hawk to make sure you do it. Stand up there and watch you like a hawk, and that is their job. They come up there morning to evening and watch you like a hawk to make sure you do it, because that is part of what they have to do. And offshore, enhance environmental service staff if required, because you would need ongoing cleaning, you would need ongoing sanitizing. I am getting complaints continually about how badly sanitizing is not happening. It is not happening, and I don't know why it is not happening, but it seems to not be happening. Communication. Regular communication about the outbreak and outbreak measures should go to unit staff. Separate communication should be sent broadly. I get complaints about people getting infected and the staff members only hearing through the grapevine, or you're in here that is COVID that so and so have. That is why they're not in work. You're in hearing that is why they're not here. And they feel very, very afraid that they have to hear that on the grapevine. They should have been called in and said, we have an outbreak happening. We have 5 members of staff that are now out because of it. Even if you don't want to say, doctor so, nurse so, whatever, but at least there's that clear communication. A media plan should be prepared to ensure that, release statements about the outbreak and ensure that what is done correctly. And by the way, let me show you a perfect example of how not to do a media statement. A perfect example of how not to do a media statement. Oh, where do I have it? So you telling me you have a situation where patients getting sick, staff getting sick and scared, union representative speaking out, and your media release would start with "Stop Public Mischief." That is how you starting to talk to the people who are scared for their lives. Stop public mischief. The TRHA notes the public mischief in several quarters to destabilize the management of COVID-19 and to create mischief and public distrust, which is dangerous and can result in panic within the population. Outrageous claims and exaggerations estimate the number of COVID-19 cases arising from that are dishonest and loaded with dangerous intent. And even after you say that, a couple of days later, you come and read out a long, long list, and it's 67 people on the list. So instead of coming and assuring us that it is under control, admitting that yes, we have a situation, because I think, and this is the other thing that is critical. The other thing that is critical is I don't know that one of the basic things in EPI, one of the things I teach my students all the time is that you don't judge an outbreak by the number. This is a very basic public health, very basic EPI concept. You don't judge the outbreak by the number. So if we had 0 cases before, and now we have 2 cases or we have 5 cases, it is an outbreak. In our minds, I know we probably think of outbreak as 100 or 1,000 or plenty. No, in epidemiological terms, an outbreak is more than what we normally have. So if we normally have 0 and we've had 0 for the last year, 2 years, 3 years, 10 years, if we now have 1, heaven forbid if we now have 2, we have an outbreak, and we need to be very concerned, because if we can identify 2, it means that there are about 10 others somewhere that we have not identified as yet. So we need to be very, very careful that we are not saying we don't have an outbreak just because we only have 30, or we don't have, no, that is not how you think about it. The fact that you have 18, which I think was the number in the press release last week or week before, means we have a problem. We do have a problem. The fact that we have 18, the fact that we have whatever, we have a problem, and we needed to respond. No, the thing about public health and public health management and emergency management is that it is better to over exaggerate your response and then realize, oh, okay, I didn't need to go so far. I didn't need to go so far. And, waste a little bit of money because you buy too much gloves, or you buy, that is the better way to do these kinds of responses, instead of saying, well, it's only 18 or it's only 20, so we don't have to respond in such a drastic way. We can't think of it like that. We cannot think of it like that. So let me go back to this really quickly. Almost done with this. Almost finished with this. Outbreak investigation and management. No. Outbreak and containment. All of those, I did those already. Interrupting, went through all of that. Good. Went through all of that. Communications, here we will. And then you need to continue monitoring the transmission and so forth. All patients should be assessed twice daily to make sure that there are no COVID symptoms. Because remember, even though COVID-19, you can get COVID and you could be asymptomatic, or you could have very mild symptoms, or you could have moderate symptoms and be home and treating your symptoms. Remember, we've always said that the people who are most at risk for getting a very bad response to COVID-19 are people who are already sick. So the fact that this is in a hospital means that we are dealing with people who are already sick. And because we are dealing with people who are already sick, we have to go the extra mile to ensure that it is not promulgating, and to ensure that we are not making our patients who came into the hospital for them even more sick. And then, of course, at the end of it, we need to go to the point where we can actually declare that the outbreak is over, because we've done all of those things that we spoke about before. We've done all of those things, and we are now saying, yes, we've managed it. We're not getting any more cases. Those who are sick are already, we have them contained. We have them it's not just multiplying. We have control. So I just wanted to spend a little time going through that, and to show that, one, this isn't even um, this isn't even rocket science. This isn't even Dr. Faith showing that, well, she has a public health degree. And no, no, no. These are mechanisms that are already in place in other places. And all we have to do is learn from them. All we have to do is learn from them to ensure that we are not making stupid mistakes, because we can do way more if we don't allow ourselves to just make the same mistakes that other countries made. We have an opportunity to do that, and we are not doing it. I don't know why we're not doing it. I don't know why we are not doing it. We have an opportunity. So I am saying that I did this today to do several things. One, even though our borders are open for the most part, and even though we have less restrictions, we have our fast food places open and all of that stuff, you all need to be very, very careful, because our numbers in Tobago are not going down the same way the numbers in Trinidad have been going down. They are not. And I know when you see the 18 a day and the 20 a day, it doesn't look like plenty, but you have to consider that we are comparing 18 out of 60,000 compared to 100 and 200 out of 1.2 million. And when you do the basic math, when you do the basic ratios, our numbers in Tobago are actually pretty bad compared to the numbers in Trinidad, because of our population size in Tobago and the number of positive cases we are getting compared to their population size in Trinidad and the number of positive cases they are getting. So don't be comforted that is only 20. Remember, it's 20 out of 60,000 versus 2 or 3 or even 400 out of 1.3, 1.4 million. We have to look at the actual numbers and see what's going on. So let me just go through some of these questions to make sure there isn't anything that I have missed, any questions that I could answer. Again, share the Cheryl is asking, have they opened any more vaccine places in Tobago? Is Scarborough, is Roxborough Hospital being used for anything COVID related? Roxborough Hospital is actually Roxborough Health Center. They haven't opened the hospital part of it just yet. The sites that I am aware of in Tobago are the 3 health centers: Canaan, Scarborough, and Roxborough, and Magdalena. I don't know. I saw that the Minister of Health announced over the weekend or whenever that from today you should be able to go to any health center, every health center, and get a vaccine. I don't think that is available in Tobago just yet. So the only thing COVID related that's happening at the Roxborough Health Center is the COVID vaccine. You can get vaccinated there. I know that we want the borders open, but it's a big risk, especially now with the variants out there. Yes, and with borders opening, we have to be even more careful. I did answer the question about the Roxborough Hospital functioning. Because it is not. Yes, we've always been classified as third world and have the brilliant opportunity of previewing the mistakes and the successes. Always, that is exactly what I've been saying forever, forever, forever. Yes, I have been sounding the alarm, and I hate the fact that I have to keep. I hate the fact that I have to say "I told you so." There's, sometimes as women, we just take pride in saying "I told you so," especially if we're doing it with spouse or with children or whatever. This is one of those times I hate the fact that I am saying "I told you so." Yes, the reporters need to demand answers, and yeah, I agree. Only playing politics. Unfortunately, that is what is happening. Gypsy is saying we, the public, should really avoid the hospital. What about attending clinics and visiting the pharmacy? And you see, that is the risky thing, because we don't want a situation where people avoid going to the pharmacy, don't get their medication, and then get more sick with non-COVID related illnesses. We don't want a situation like that. We don't want a situation like that. So we have to figure out how to manage it quickly and allow people who sick with other things to get their basic treatment. Basic treatment. Cheryl was saying, stay away from the hospital. Imagine we have to say that. You know that it's bad. You know it is bad if that is what we have to say. Let me see, go through some of the other questions here. Are the health centers at risk via the hospital? It depends on the management of the staff. If there are doctors or nurses that are working in the health centers and the hospital, which there shouldn't be, there should be a complete separation, but I don't know what they're doing. So there shouldn't be any cross contamination, ideally, but I don't know. I don't know that they are not swapping in and out workers because they're short staffed. I don't know. Ginger is asking, what are the effects of COVID on toddlers? So what we're seeing is that young children are not having horribly severe symptoms. Young children have been getting what is known as MISP, which is a multiple inflammatory syndrome. What does the P stand for? I can't remember what the P stands for. But basically, for younger children, they are getting inflammation in different parts of their body when they get COVID. But I think I've heard them say that we've only had maybe 1 or 2 cases of MISP in Trinidad and Tobago. So thankfully, we are not getting too many cases of that here. Dunson is saying, I submitted my application for appointment over a month and haven't gotten a response. What should I do next? I think you should submit it again. You should call again. You should send it in again. I know that they have been, for example, at Magdalena, they've been calling different categories of workers. So there was a point where they were saying construction workers come in, tourist-related workers come in. Now that there are some companies that are saying you have to get vaccinated to get work. I don't know how they're doing that in Tobago, but I would apply again. I would apply again to go in, or I would go to one of those kind of mass calls at Magdalena if you have it. Yes, Kawasaki disease. Yes. That's the that is so it's not exactly Kawasaki disease. It just looks very much like Kawasaki disease. Yeah. Jim is saying, I will be rescheduling my clinic appointment and getting someone less at risk than I am to fill my prescription. Actually, that's a good method, because if you don't absolutely have to go, then you shouldn't. But yes, and you could send somebody else to get your prescription instead of you going and putting yourself at risk. So you definitely stay home, stay within your corner, and not necessarily put yourself out there, particularly if you don't have, if you have to travel and you have to then go in, into a maxi, and those things that once you get into more contact with people, those things put you at risk. Dunson says, you don't fall into any of those categories. I would have to find out. What happens if I would have to find out what is their plan for Tobago. I'll call a couple people and see what's going on, to see if they are going to open up to other health centers, because that would be the easiest. If, for example, we know that we could get 2 or 3 vials in Bell Garden, and people in Bell Garden could just go to Bell Garden, that thing. Ginger is asking, can COVID-19 cause a person who has seizures to have brain fog after a long period of time? So one of the things you're talking about is what is known as long COVID, LONG. I think I'm actually going to do a live about long COVID, not LUN, LON, long time, as in time, because we're realizing that there are people who've had COVID who got better, as in the acute illness got better, but then months later, they're realizing that they're still very tired. They're realizing that brain fog. They're still having brain fog. They're realizing that, when they used to be able to run up steps and exercise normal and stuff, they can't do that as well as they were able to do it before. All of those things, we are recognizing that there are a lot of people, quite a bit of people who have that long COVID. And I am going to outline the I think I'll do a live where I speak specifically about long COVID and all of the signs and symptoms that people seem to be getting after a while. So, yeah. So I think those were all of the questions that I saw. Again, guys, thank you. Uno, let me share this one thing before I forget. Share screen. On Sunday, if you are in my district, Goodwood Bell Garden, which is from Bell Garden all the way to Mount St. George, or even if you're not in my district, but you just want to be a part of the conversation, I'm having my first accountability meeting on Sunday afternoon, Conversations with the Community, Sunday 25th, which coincidentally is exactly 6 months after election. Anyway, it's going to be on Zoom. Here are the Zoom credentials, so you could be a part of the discussion where we will talk about some of the things I've been able to accomplish in the community. We could talk about having members of the community identify what are some areas that we could work on now, even with the 6-6 or in the future. And we can work on what are some of the outstanding projects so that they can be documented. So even if I can't work on them right now, that we would have them documented so that we know that this is what we are going to do as soon as we resolve the 6-6 issue, kind of thing. Yeah, so that is Sunday afternoon at 5 p.m. via Zoom. If you're in the district, you can jump in. But even if you're not in my district, you can jump in and be a part of the conversation. Thank you so much. Thank you. That's why I jumped into politics. If you need me, let me remove this banner. The email address is also there, assemblyman.drfate@gmail.com, or you could WhatsApp me or WhatsApp my office for more information about this if necessary. All right, so I think that is it. That's it. Again, thank you all so much for tuning in. Thanks for those of you who stayed, even though we had the technical issues up front. Oh, by the way, I don't know what happened. I think my computer is trying to figure it out. If you recognize, I actually have a brand new camera that I am debuting for the first time today that I love. I love this camera. I absolutely love this camera. It is the best choice that I've made in a long time, long time. So thank you so much. I'm so happy I got it and it came quickly. What can a person do? Mild symptoms like fever and loss of taste. I don't know what you could do with loss of taste. Because loss of taste and loss of smell are symptoms. I have no idea what you do. If you have mild fever and so forth, you can take like paracetamol, any of the cold and flu kind of Panadol, multi-symptom and those things to help you. If you have mild symptoms, then you would need to call the you don't have to go to the hospital because they don't have space they don't have space, and we need to save the spaces at the health facilities for the critically ill people. So if what you have are mild, then you need to isolate at home, stay at home, try to separate yourself as much as possible at home, and try to treat it with like paracetamol, cold and flu, drink plenty, the typical fever grass and the lime bush and fever grass and the lime and a little percentage, all that stuff that we know about, that we've been using to treat our cold and flu symptoms for all of these years. We could continue doing that. That is really what we have to do right now. All right, guys, so I've been here for way longer than I had anticipated. Again, thank you all so much for tuning in. Share this live with other people who may be interested in hearing what I had to say. And let's just be careful. Let's be careful. Don't let up now. Don't let up now. You have to keep washing your hands, keep sanitizing, keep wearing your mask and wearing it properly. Go and get the vaccine. Go and get the vaccine, because the vaccine is what is going to help us prevent this continued spread, prevent the variants from multiplying and getting worse and that kind of thing. Keep washing your hand, keep social distancing, keep not congregating and no zesting and all of that stuff. Because the longer we take to kind of stop and slow it down, the more dangerous the virus will become. And we don't want that. We don't want that at all. All right, guys. So thank you all so much for tuning in. Thank you for participating in this. Thank you so much for continuing to have the conversation with me. And I am going to continue to unfortunately sit on the outside and do the best that I can do, which is at least educating, at least giving the information, and then let's hope and pray that we are in a better situation in a not too distant future. So again, thank you so much and have a blessed and safe day. Bye.